Okay, we've been focused pretty much on the recipient side of things, naturally, Transplant Recipients International Organization, but we never forget our caregivers. And quite often, we're so involved with our medication, our medical challenges, our life, that we forget that loved one that's right next to us. I'm looking at your lungs there, and your wife next to you, and it just matches what I'm about to say. And so we have Mike Lokovich from the Treatment and Evaluation Center at the University of Pittsburgh coming to talk to us about caring for the caregiver. And so hang on to the thoughts here and see how you can take this home with you into your family life and do something special for that person who you often acknowledge, but sometimes we don't acknowledge enough. And so Mike, whenever you're ready, come on up here. He's a certified grief interpersonal problem-solving therapist, currently working as research therapist in the HEAL study. I don't know what the HEAL study is. He'll explain that. To improve the treatment of complicated grief.
This is me. I'm also named as Mike. I'm also Mike. My name's a little easier. This is my thank you screen. And it's very important because there's some famous researchers up here, and I admire them. I work for them, and I admire them as much as I could admire anybody. And you know, when I agreed to do this, agreed to speak to you folks, I do that because when somebody asks me for help, I say yes. That's what I do. And after I started reading at it, I said, oh my gosh, I've had patients that have had transplants. But what do I know that I could share with these people? You know, so immediately I contacted Mary Amanda Dew. I don't know if you know her, but she's a famous researcher in transplants. She spent her whole life researching transplants, and a wonderful person, has mentored many, many people. And I said, Mary Amanda, I'm talking to this group called TRIO, and I'm wondering what I know, you know, and how I can help them. And she said, I said the name of the talk is Caring for the Caregivers. So she said, okay, and she sent me a bunch of stuff, and I read it all again, you know, and I said, yeah, Mary Amanda, I read this, and I think you are the most qualified person in the world to do this talk. And she said, Mike, you and I are a therapist, and that's all I've ever wanted to be. And you know, I really, believe me, I love some of these people, all of these people on here, but I never wanted to be them. I always cared more about the next person in the lobby. And so when Stephanie was talking about a Jedi, I'll get to that in a minute, Mary Amanda Dew says, what's the name of the talk? I said, Caring for the Caregiver. She said, you're the one. You're the one to do it. She's trying to tell me I was a Jedi. I was thinking about that. I said, Mary Amanda, there's another part of this story you don't know. I had on April 4th, 2011, my brother died when a heart transplant didn't go well. And we were not close. My brother and I had not been close for long years, but in the last hours of his life, we were close again. So I don't have that experience of the whole process that you folks have. I said, Mary Amanda, I have the process of when everything goes wrong. And she, of course, said, you're perfect. She said, you're perfect. So these are the people I want to thank. Dr. Reynolds, who's our director. And of course, Mary Amanda, who's also one of our principal investigators. She's a transplant researcher. And Larissa Majaskovsky, and all of my colleagues and friends that work at the center. Who we are, we're the Late Life Depression Prevention, Treatment, and Evaluation Center, part of PIT. We conduct research locally since 1989, and we've been designated as a Center of Excellence by the National Institute of Health since '95. Our mission is to advance the prevention and treatment of depression in Western Pennsylvania, Eastern Ohio, and West Virginia, and to extend these advances to the rest of the country and around the world. Our center is directed by Charles F. Reynolds III. It operates from our offices in Oakland. We have other sites in the community, and we do a lot of work in the homes my boss, Dr. Reynolds, loves this slide. I have to include it in everything I do. We became a center. We're now a center by the National Institute of Health for the treatment of late life depression. And that word late life, most of the time it means 60 and older. Okay? So when you hear that, that's pretty much what that means. We deal with people that have the same. If you can see, we deal with people that generally have the same hair color that I have if you look really closely. So we deal with seniors, but we're primarily looking as a center at the vulnerabilities that sort of make seniors susceptible. And their physical vulnerabilities, psychosocial vulnerabilities, and cognitive vulnerabilities. And we're working in all these areas in research studies that overlap. And we're working on depression. And this is what Mary Mandy was trying to yell into my ear, that I already know. What I already know is that our goal is to prevent the onset of depression in older adults and to bring existing depression into full remission. Because that I do know about. And I know that depression is among our most serious illnesses and that it kills people. It shortens seniors' lives. It shortens young people's lives. And that's what we're about. And in older adults, it complicates physical problems, degrades, you see all the things there, decreases physical activity, degrades quality of life, makes people socially isolated, and it undermines your ability to live independently. Among transplant patients, recipients, transplant recipients are at risk for depression at every stage of the transplant process. At evaluation, and I know you folks all know this, I'll go over this quickly. Been living with end-stage, most people, in many cases, not Jackie's case here, but have been living with end-stage organ disease for a long time. And with that deterioration and the effects that it has on your mind and your body. During the waiting period, the same thing continues. But added to that is the uncertainty as well of will an organ be available for me? Will there be a suitable donor? The effects of medication and new treatments and new procedures, and concerns about the risk of surgery that's ahead. All of these things are stressors. All of these things put people at higher risk for depression. During the surgery and the perioperative recovery period, adjusting to the immunosuppressant medications and the side effects. And sometimes people that were on existing medications to help with depression, sometimes those are stopped for periods of time. And a person is left vulnerable to a return of depression. During the first year post-recovery, it's usually a brighter period for many people, but sometimes recovery can seem slower than you had expected. There's coping with graft rejections and infections, adjusting to a different kind of life, a less illness-focused life. All types of adjustment create stress. Accepting life with a donor organ. Coping with financial issues, and this is no small thing. Complex follow-up care, medication regimens, relationship stress, PTSD that Jackie was talking about, and rehospitalizations. In the longer term years, all of the stressors that everyone has in life that were there before come back in and reassert themselves. The non-transplant life stressors that people have. Complications from the long-term use of immunosuppressants, the development of chronic rejection, perhaps a return to dialysis or the need for retransplantation or a new transplantation of another organ. So all these are risk factors that put people vulnerable, that make people, recipients, more vulnerable to an onset of depression. Caregivers, however, and this is that talk about caregivers. Caregivers are also at risk for depression. A recent study of heart recipient and lung recipient transplant caregivers found that their physical functioning and their bodily pain worsened across the first year after transplantation. And that's compared to normative controls. That's so, and on top of that, these greater impairments in caregiver health, in their perception of their health, predicted poorer patient survival, independent of what the patient's health status was. What this means is that caregivers' well-being affects patient well-being and survival time. They're all linked together. They're linked together. This is the kind of research I so much admire. There's a circular connection between the caregiver and the recipient. Another study found that the depression that's experienced by liver recipients affected their subsequent physical well-being and survival time. So depression, this is what I was telling you about. Depression is a lethal illness. It's among the highest levels. You know, the AMA lists the most serious health threats, heart disease. That depression is among those. Other studies indicated that rates of depression and other distress, such as anxiety, are elevated, and that family caregivers are as likely as the recipients themselves to develop depression, and that's higher than the normative average. Okay? Therefore, it's important to prevent depression and treat depression in both recipients and caregivers, because they each affect the other. Okay? It's a family. It's a system. Right? Okay. So, why research? Why look into research? And I'm going to share with you guys for a moment that I used to work in a very, very busy treatment clinic in Oakland. One of the busiest in Pennsylvania, as a matter of fact. They did statistics on that. And remember I told you it was perfect for me because that's what I wanted. I'm sort of more directed to seeing the next one in the lobby, right? But there's something I always wanted to do, and all these people I saw, because of the limitations of our healthcare system. I always want to see what it would like to put some of these people in a Cadillac. And this is a personal opinion, right? I've been driving them around in Fords that are sometimes patched up because that's the best our health system can do. Okay? I wanted to see what it would be like to put them in a Cadillac or a Lexus. So I went to work for those people I told you that I admire so much. Right? And so why research? Well, with research, you get a comprehensive evaluation because no good treatment starts without that. There's no way around that. No good treatment starts without that. There's ongoing informed consent and a partnership. And what that means is that if you're in research, you know everything that's going all along the way. And it's like a partnership. And they take the time to do that. And that's something that I value a lot. It's compassionate care and very close monitoring of progress. I can say this, that generally, if in research, you will get more attention than is possible in the community. I can say that without a doubt, usually by far, than is able to happen in the community. We have a 24-hour on-call availability. That's just a part of it. And this is a big one. The next one I put on here, there's no cost and no charges. And from everything, I highlighted that stuff after I read some of the financial burden that organ recipients and their families sometimes face after these operations. So another good thing about research is that for treatment studies, there's no cost. It's paid for your tax dollars and mine pay for it. There's always close coordination with your healthcare providers, you know, your team, your other treatment teams and your specialists. We value that, and that's also very important. Our prevention studies do not involve medications. And I like to say that a lot because, you know, I see a lot of folks that the idea of one more medication is pretty hard to face sometimes. The other thing is that, and this is the last one is one that I just love. I'm so surprised and so pleased all the time to see how much some of our seniors really like being a part of something bigger than themselves. I know I do. And that's the opportunity to help other people, and people you don't even know, and to be a part of something. So we do a lot of different kind of research studies at our center, but there are two types I want to tell you about today. There are prevention studies, and prevention studies are all aimed at preventing the onset of depression. And if we were a bigger center, 1, 2, and 3 on this list would be 4, 5, 6, 7, 8, 9, and 10. But on this environment, in Washington, D.C., we are just thrilled to have 1, 2, and 3. And what 1, 2, and 3 means is these are some of the biggest risk factors among seniors for depression. Believe it or not, knee arthritis, in terms of sheer numbers of people, is a huge risk factor among seniors in terms of sheer numbers. Mild memory changes is a risk factor for depression. Again, big numbers, and we're looking for the biggest numbers we can reach. And the third one, there's no correlation between getting home health services and depression. Home health services do not cause depression. There is an indication that the people that have to get them have higher levels of depression. Okay, so there's no correlation between cause and effect. But people that are receiving some type of in-home services tend to be at much higher risk, and I'll explain that. And then there's the treatment studies going down to the next level. And of course, we treat people with depression. Of course. We treat people with depression, and another very large contributor to depression among seniors, which is lower back pain. And the third is a study that's sort of a unique study, because we're one of the first centers one of the first centers in the world to do a second-generation study on complicated grief. We were the first center in the world to do a major landmark study on complicated grief. And I'll talk about that a little bit later. I'm going to try. So our goal is to provide individuals with strategies and tools to manage stress. These are our prevention studies, okay? Is to provide individuals with strategies, tools to manage stress, physical problems, to protect brain health. This is the way we look at it, to protect our brain health, and to maximize and maintain our personal independence for as long as possible. Now, in our prevention studies, we don't use experimental procedures. These are all tested and approved procedures that are known to be effective. The way we're applying them to these different groups in this different way, that's the experimental process. How they work, how we're able to deliver them, how transferable they are to the rest of the community. Remember I said reaching out to the world and the nation? How transferable they are. That's the experiment, not the methods themselves. Okay? The methods we use is we work on improving sleep, managing knee pain, as you saw there, increasing healthy exercise and flexibility, relieving and reducing stress, improving problem-solving skills and thinking, okay? Decreasing social isolation and loneliness, increasing personal effectiveness so people feel like they have more agency in their life, and enhancing independence and self-determination. That's what we're looking to do. Those are the things that will help people to age in place for as long as they want to, hopefully, right? Okay, so it's all about protecting brain health. This is prevention, and these methods help to do that. Threats to it lead for depression, memory problems, early disability. That's what we're doing. Okay. Now, studies all have names that are like this long, right? So we give them all nicknames. So what you're going to see are the nicknames, okay? Our first study is a true caregiver study. It's a dyad study, and it's called recall. And recall, remember I told you one of the main stressors is mild memory loss? And mild memory loss can happen from a lot of reasons. It can happen from medications. It can happen for a lot of reasons. And it's a stressor. It's a stressor on the person that has it, and it's a stressor on family and caregivers. So it affects both. Now this study, how does it work? It provides help with the person that's having the mild memory loss and the caregiver. Both are at risk for depression. Both get treatment. Okay? We use a brief therapy that improves problem-solving skills, increases flexibility and exercise, and sleep quality. That's a dyad study, which means we take in two people, the The person experiencing the memory problems and the caregiver both enter treatment together. Our second study, the nickname for our second study is called RAPID. And RAPID is the study that deals with stress and knee arthritis, a big precipitator of depression among seniors. It causes stress and worry and concern. It affects your ability to be independent. It detracts from quality of life. It affects sleeping and waking time. Often we'll find people that have knee pain that aren't able to sleep during the day or the night because if any of you have ever had serious knee pain, it can feel like the painful tuning fork that never stops. So it affects waking and sleeping time. It leads to inactivity and deconditioning, social isolation. People aren't going out. So what do we do? In our knee pain study, we help people with physical therapy, and we have a particular type of counseling that's directed, a targeted therapy to improve pain management, to enhance activity, and to manage stress that's specifically targeted to sufferers. Our third study they call Depression ABC, and it's the one that's focused at those receiving in-home services, okay? Because our research shows that people that have that have more stress, they're at higher risk of becoming isolated, they have less satisfaction with their life, and they're less independent. So what do we do with that? This is the study that visits people in their homes. We use brief therapy that seeks to enhance problem-solving skills, improve interpersonal effectiveness, and decrease social isolation. It helps people to age in place. And again, the goal is to live at home and to be independent for as long as possible. Okay. Here's the formula for the prevention studies in a nutshell. Prevention leads to better brain health, leads to a healthier lifestyle, leads to increased independence. That's what we're after. Okay? Okay. Given all of this, many, many seniors come to us who are already depressed. Right? Many, many. So we have depression treatment studies. We actually have more than this, but these are the main ones. And the first one, nickname is Earl Grey. Not spelled the way, I have to tell you, Dr. Reynolds, this is a like 3-city study, so there's collaboration. Dr. Reynolds never liked that title. I don't like that title, but they all have titles. So this one's Earl Grey, and it's to help seniors actually get remission from depression. And it's actually the second part of the study looks for the hard-to-treat depression, which Dr. Reynolds is very interested in depression that's hard to treat and making progress on that. We have an ADAPT study, and that's the study that helps seniors suffering from depression and lower back pain. And then finally, the HEAL study, which Jim mentioned, is our study for complicated grief. And it's the only study where we actually, in terms of what we're used to, we go into the nursery and we get 18-year-olds, 18 to 95. And so far in this study, we've had an 18-year-old and we've had a 92-year-old. No 95-year-olds yet. And this is one study where we reach out to a much broader population we've ever done before. But it's to help people that have lost someone close to them at least 6 months ago. And the grief is still interfering with their functioning. And I'll talk a little bit more about that if there's time at the end. But first I want to get to our treatment study for depression. Earl Grey. Again, it's people 60 years old and older. We do have there is an adult program on the floor above us that has studies for adults that are younger than 60. And I can connect you up with them if anyone has interested in that. Eligible participants, again, receive a comprehensive evaluation, the informed consent. Again, this study is actually looking for hard-to-treat depression. It's looking for difficult or protracted depression. But in order to know who has difficult and protracted depression that's hard to treat, we treat everybody, try to get them well, and we know, do the state-of-the-art treatment to get them well, because we know there are a percentage of them that will not get well with state-of-the-art treatment. And that's the group we're actually looking for. That's actually where the science starts. So the first 12 weeks of this study are directed at getting a person well. The second 12 weeks are where the science starts with the folks that are having, that have that obstinate kind of depression that doesn't get well with standard treatment. Okay? And again, the treatment is at no cost. There's close monitoring of progress, the 24/7 availability, and close communication with your other treatment providers. Okay? The depression and lower back pain, basically the same eligibility requirements, except that a person has chronic lower back pain that's lasted at least 6 months and has been at moderate intensity for at least 6 months. That's the threshold we use to treat somebody. And of course, all of the other benefits of research that I talked about before. The complicated grief study is a little bit more complicated, as you can see by this very busy slide. I'll just sum it up briefly. Prolonged, it used to be called prolonged, protracted, or traumatic grief. And this illness is a killer. Because if you've ever known someone, and there's research that says as many as 1 to 1.5 people in every 10 that when they experience the loss of someone close to them will have this kind of grief. And these are the people that never seem to pull out of the grief, are never able to really integrate the grief or move on with their life. It shortens lives. I've worked at Western Psych for some time now, and this is some of the most intense emotional pain that I've experienced in treating people. It's and it can go on for years and years and years. We routinely see people with 2 years complicated grief all the time, 10 years every week. I've treated people with 20 years. I treated a person that had 38 years complicated grief, and I treated one person, and I had to see this myself because I had to be convinced myself. 59 years. And after treatment, first of all, the complicated grief changed the trajectory of her life fundamentally. After treatment, she made changes in her life that were astounding at 70 years old. Astounding changes. So this is and some of the seminal research for this was done here in Pittsburgh. This is a second-generation study also done in Pittsburgh, and it's also at 3 other sites at Harvard, Columbia, where Catherine Shear, who developed this, is, Pittsburgh, and University of California, San Diego. Okay. For that study, 18 to 95, and I know we might be running all of the benefits. I'll let you read the slide yourself. All of the benefits that come with research, close attention. And again, we're comparing, this is a study that's looking for the best treatment, not test. We know that the different modules themselves are effective. We're looking for the best and most effective treatment for complicated grief. Our center, it's real easy. If you want to know how to get help from our center, you call the number and you'll get a clinician, and a clinician will talk to you and answer all of your questions. So access to our center is as easy as telephoning. Okay? And these are some other resources, and I'll let you look at them because a lot of you folks are out of towners. This is our group. This is our group at Belfield Towers, which is our headquarters. Actually, our group is bigger than this, but this was who we could round up on a cold April morning. They're all April. So, with that, I want to thank you for the time you've given me, and I'll answer any questions that you have.
Mike, just out of curiosity, how do you share the results of your work so that those of us who are not from the Pittsburgh area benefit from what you learn and practices that change because of your work?
Well, that's great. We have a fair number of our partners or our volunteers who are interested in, they want to know the results too. So as soon as we start publishing, as soon as we close the study and they start publishing, we have a whole list of people that want copies of the articles. right? They want them right away. And that's one of the best parts, sharing that with them. So how we do it, as soon as it comes out, our partners usually get it first, and usually one of the requirements of being a center is we need to go out and do talks like this. We need to share them with people. That's one of our responsibilities to the community.
Okay. I got it. Go ahead, question?
Do you bring spirituality into it at all?
Wow. You know, you absolutely can't do this unless you do. Because you know what? My patients bring spirituality in the door with them. And you know, what Mary Amanda was trying to tell me a long time, and it's absolutely true. I learned most of the things I know from my patients. And when my patients come in and spirituality is important to them, that's what we do. Right?
Yes.
That's a good question.
Does your center have a website?
Yes, it does. And you know, I didn't know about the packets thing. I get brought packets out for you guys, and they're here somewhere. Someone's going to pass them.
And I'll edit your slide.
Okay.
I'll put a blank slide behind this.
Okay.
Or let's grab one
Grab
that
that
we got. And what's the website address?
Oh gosh. I have it back in. I'm not good at that kind of stuff. I do have it though. I did bring it, but I didn't want to put it in your packet because I thought it was. I didn't want to make it any fatter than it already was. But I will get you that. It's I just can't remember.
Okay. If you get it to us later, I'll make sure we bring it to their attention.
Sure.
Also, in the elderly over 60, isn't there a natural depression because of loss of living spaces, moving to a nursing home, or loss of possessions, or that kind of thing? Do you deal with that?
You know what? There are losses. There are definitely losses associated with growing older. No question about it. Just try to watch me keep up with my son sometimes, and you'll see it. But you know what? Depression. This is a very important point. And I want you all to hear this. If you hear one thing from me today, hear this. Depression is not a part of normal aging. It is not a part of normal aging. No matter whether you lose your mobility, whether you lose whatever. You know, ooh, are you okay, dear? My mother was in a nursing home, and I lost her in May. And she was getting depressed about a year and a half before that. And I got her the help of a good psychiatrist. And he brought her around, a good geriatric psychiatrist, and he brought her around. And you know the email I sent him? She died on May 15th, and I think it was May 30th I sent him an email. And I thanked him, because I said, you validate what I say every day. My mother died. She was going to die, but she didn't die depressed. She died the day before, 2 days before Mother's Day, and we had a nice Mother's Day.
And it's much more than that. Steve?
Mike, as you looked at the caregivers and transplant recipients and the effects, depression, likelihood, etc., did you find any correlation between the type of organ received and the likelihood of problems? You know,
that's an excellent question, and I asked that question to Mary Amanda. She's my guru on this, right? And she said that was one of her calls for more research. When she did her studies, and she does all kind of peer reviews and all kind of things, she put out a huge call. There needs to be more specific studies for different types of transplants to track this. We only have the ones that we have. And that's why you saw the one I talked about, liver recipients, the other one I talked about, lung and heart. That's because that's all we have. And boy, she would like you today, because that's her clarion call. I'm sorry, that's the best answer I can give you.
Thank you. Question over here? Question went away? Not you, Ron. Did you have a question in the front row here? I'm sorry.
I was just going to ask if your studies for the HEAL program were only about those who have lost someone, or if they were about the loss of not just maybe a number or a loved one, but like loss of a job.
Loss of a job, loss of a relationship,
right.
Loss of health. All of these things you're talking about,
Is that
you know,
included in that study?
no, I wish it were. And again, you know, this might sound, to some people, this might sound like no, but even a loss of a pet. The loss of a pet can be devastating to people, you know, but like, you know, the environment that we're talking about, this is what we can do right now. Those are all valid losses, I agree with you, but right now it's just the loss of a loved one.
I was just curious.
We get that question a lot.
Great. Okay, so no other questions? Mike, again, thank you very much.
Thank you.
And great reading and back. And so along with the work, some words of inspiration you can share with patients to get them out of depression. How's that?
Thank you. You didn't have to do that.
Thank you. Don't forget to get back to the microphone.